Hi, this is Dr. Bernstein with Dr. Bernstein's Diabetes University and our August 2020 teleseminar. Before we answer questions, I want to go over a few new publications that came out on the subject of diabetes. Here's one from the journal Diabetes, August 2020. This is an ADA journal entitled Brain Function Differences in Children with Type 1 Diabetes, a Functional MRI Study of Working Memory. Basically what was done was PET scans were done of the brains of children while they were solving problems. And you could, in effect, see the metabolic activity of the brain as they were puzzling with problems. And they were compared to the activity in non-diabetic children. And as you might expect, the diabetic children were rendered so-called optimal care, and for the ADA, that means that their target blood sugars were, their target hemoglobin A1Cs were something like 6.7%, which is an average blood sugar that's more than double normal. And what they found was that the diabetic people had impaired brain function, and they conclude, interestingly, with the following statement. Future studies that test whether these patterns of change are a function of improved glycemic control are warranted. And then we get another study in another ADA journal, Diabetes Care, same month, August 2020, where they actually gave high doses, high blood sugars to diabetic teens and did the same studies and found that when they got their blood sugars up to 360, there was significant impairment in the brain function compared to blood sugars that were closer to normal. So there's both short-term and long-term effects upon the functioning of the brain in diabetics caused by high blood sugars. And as I fully know from the questions that I get from viewers of my videos, that many endocrinologists are chastising parents because they attempt to keep their kids' blood sugars normal, and they're telling the parents that for diabetics, high blood sugars are better for the brain, and normal blood sugars will stop the growth of the brain, which is exactly the opposite of the truth. Here's an article from the Journal of the American Medical Association. You would think that it would be a wise journal, and it's about distal symmetric polyneuropathy in the year 2020. And they point out wisely that the great bulk of these cases of neuropathy occur in the feet, occur in diabetics who have high blood sugars. And this is a review of the different substances that are being tried to be given to people with neuropathy, not just substances, but also acupuncture and psychological treatments and so on. And they review all of these substances and treatments, and nowhere do they mention normalizing blood sugar, which is the one treatment that is effective for diabetics. So we have Journal of the American Medical Association. Next article is, I found quite interesting, enhanced release of glucose into the intraluminal space of the intestine associated with metformin treatment as revealed by PET scan. And this is also in the journal Diabetes Care in August of 2020, and it tells us that one of the many effects that metformin has on the body is to cause excess blood sugar to be released into the intestines, into the stool. So here we have these a class of substances called SGL2 antagonists, which get the user to put glucose into their urine, forcing a lot of glucose through the kidneys. And now we learn that metformin gets glucose into the stool. I think it's a lot safer to get glucose into the stool to lower blood sugar in that fashion than it is to force glucose through the kidneys, where it can potentially do harm. Now, there are other mechanisms by which metformin has been found to lower blood sugar, but this is the latest. This is an article that I cite because it reiterates something that I've been saying for a number of years. And this was for Diabetes Care, August of 2020. You may recall that many doctors, cardiologists, endocrinologists are talking about blood cholesterol, which has been shown not to be a predictor of cardiac disease. And here, and I've been pushing, amongst other things, apolipoprotein small a, and the title of this article is The Association of Lipoprotein small a Plasma Levels with Prevalence of Cardiovascular Disease and Metabolic Control Status in Patients with Type 1 Diabetes. And indeed, what they find is that high blood sugars cause high levels of lipoprotein small a, and LP small a is a very potent predictor of cardiac disease. Something I've been saying for years. Here is a similar article. This time, Diabetes Care in August. All these are ADA journals. Guidelines in the management of blood cholesterol in diabetes. And you would think that this is an article indicating that serum cholesterol is a cardiac risk. No. It's pointing out that ApoB, which you could find in the serum, is a major factor in cardiac risk. That total LDL is not a significant factor. I mention, and this does not mention, that oxidized LDL and small dense LDL are measures of cardiac risk. And now another LDL-related apoprotein, ApoB, which has been discussed for years, is a significant measure of cardiac risk. So most doctors are doing the wrong tests if they want to check the blood or serum for measures of cardiac risk. They should be looking at lipoprotein small a, oxidized LDL, small dense LDL, ApoB, and the other factors that I've mentioned over the years. Here's an article comparing ordinary Humalog with the ultra-fast Humalog for covering blood sugars, for covering meals in people who are on high carbohydrate diets. And what the article says is that there's a significant difference or improvement. But if you look at their actual data and the charts that they publish, which I'm going to hold up here, these are blood sugar versus time. There's almost no difference between the two insulins given just before a meal, and you look at the blood sugar, I believe it's 4+ hours later. The blood sugar goes up to something like 180, and then, it goes up by 80 milligrams per deciliter, and then over 4 hours is still 20 milligrams per deciliter higher than it started. So the two insulins, the fast and the super fast, are ineffective in keeping blood sugars normal. And of course the reason is that it's the high carbohydrate diets. Now we're going to get on to the answers to the questions, and I want to remind you that the answers I give are generic answers. They're meant to educate all of the listeners, not necessarily solve the problem of the individual question. To really solve a problem, I have to really know a patient. And sometimes I'll be dealing with a patient for many months and not realize something that's very important that explains a particular problem. For example, I've had 2 young ladies, both of whom over the years have had periods of very high blood sugars that couldn't be explained. They swore that they were not eating anything other than what was on their meal plan, and the parents swore that they were close to them, watching them all the time, that they're never eating. And then we discovered 2 separate cases. Both of them were snacking, and their blood sugars only went up when they snacked. So without really knowing a patient, doing a physical exam, getting a complete history, there's no way that I can magically have the right answers. Now here is a very familiar story. My 10-year-old daughter Lily, by the way, my 50-year-old daughter is named Lily, was only last week diagnosed with type 1 diabetes. She is presently in hospital. I'm at odds with the medical team as to how Lily should be fed. They have told her that she can eat as normal and just take the insulin accordingly. Lily is given liberal amounts of high-carb food in the hospital, including sugary desserts in the morning to night, that has spiked her to, and we get 27 millimoles per liter, which is about 486 milligrams per deciliter. So here in the hospital, they're getting her blood sugar almost up to 500 milligrams per deciliter. They're attempting to put her into ketoacidosis. The medical team has used scaremongering tactics by mentioning stunted growth and eating disorders, which has frightened my wife. My belief is that they are an intransigent machine that refuses to accept any approach but their own. My wife mentioned your name, and the consultant said she found you to be insulting. That's me. I am in need of help. How do I win back my daughter? Well, when she's out of the hospital, I suggest that you find a kindly pediatrician, and you may have had one before she went into the hospital, and that you read my book, Diabetes Solution, and try to follow the directions in the book, which are not simple. We use diluted insulins, we use multiple insulin injections, we use a very low carb diet, and you might also contact the members of Type 1 GRIT, Type, Type-one, GRIT, G-R-I-T, which is an internet group of parents of Type 1 diabetics plus Type 1s themselves who are following my book and can help one another work through a treatment plan. I'm a Type 1 diabetic. I'm now 21 years old and have been a diabetic for 12 years. I'm just now learning that I've been treating my diabetes all wrong. All my endocrinologists have told me to eat 75 carbs. I don't know what that means, where it's 75 a day, a minute, a meal. Have told me to eat 75 carbs and take more insulin. I've been on the pump for 2 weeks, taking 33 units basal insulin a day, which is a lot, and forces you to eat. On a low-carb diet, if I am on a low-carb diet, should I use regular injections or the pump? Well, I recommend that you use injections because the rules for the pump, which are to give you extra high doses of basal insulin, which is what you're getting right now, forcing you to eat all day, and then giving you bolus shots of insulin to cover meals based upon carbohydrate, which is hard to estimate, and ignoring protein and other foods, and ignoring the bulk effect of meals, where just a bulky meal with very little carbohydrate, say a head of lettuce, can raise your blood sugar considerably. All these things are ignored with the pumps, and the infusion site eventually causes the formation of scar tissue over time that impairs the absorption of insulin and makes the amount absorbed unpredictable. So it's a game plan that predicts unpredictability. My morning sugar is 255 or more, and my doctor wants to start using Lantus insulin. Any advice on how to control my sugar will be appreciated. Well, first of all, I would suggest that you get my book, Diabetes Solution, and follow it very carefully, that you also follow the dietary guidelines, which are very low in carbohydrate, and that possibly you consider, your doctor should consider Tresiva insulin, which lasts longer than Lantus, and doesn't have the history of causing increased incidence of cancer that the Lantus has in some countries overseas. Have you looked at doing your diet on a plant-based version, but including more slow-acting fruits and vegetables? Well, the only slow-acting ones that I know of are slow-acting fruits are avocado and tomatoes. And if you don't like eating dead animals, I could suggest that you eat eggs and cheese as sources of protein. I've had patients come in who were vegetarians, who were getting very little dietary protein and were very sickly. Now, there may be some vegetarians who are not sickly. How they're getting adequate protein, I don't know. I don't know of any vegetables outside of soybeans that are high in protein. And soybeans have a problem of mimicking female sex hormones, so they're potentially hazardous. Fermented soy does not have that problem, and maybe it's possible to eat enough fermented soy to get adequate protein. I don't know. But I think it's dangerous to eat solely vegetables and avoiding things like eggs and cheese. For type 1 diabetics that have basically no insulin production or very little, is it dangerous for them to be on a very low-carb diet where their insulin requirements are zero or close to zero? I am concerned not because I think low-carb diets are unhealthy, but because I feel that a baseline amount of insulin needs to be on board for the patient to prevent DKA. Well, first of all, if you're able to have normal blood sugars without injecting insulin, it means that you're making enough insulin to prevent DKA, to prevent high blood sugars. As long as you keep your blood sugars normal, you're not going to get DKA. So in your case, it looks like you may be making a considerable amount of insulin. Please address elevated C-peptide levels in honeymoon phase and how to gauge minimum insulin requirements while the type 1 patients are still producing some insulin. It's a trial and error job, and you need my book to walk you through the experiments that you'll have to do. The C-peptide level is not a guide to how much insulin you should take, because you're not measuring it after each meal and after fasting, etc. You're measuring blood sugars, and that's what you should base your insulin dosing on, your actual blood sugars, and you have to do experiments based upon the insulin you're taking, the food you're eating, and the actual blood sugar levels, and that's why I wrote the book. I have a patient who is newly diagnosed type 1, and he has Down syndrome. His mother, he's 23, has him on a very low-carb eating style, and his insulin requirements are now zero. I am happy with his blood sugar control, of course, but I'm concerned he could accidentally go into DKA. Well, I guess if he accidentally eats a jar of peanut butter or a quart of ice cream, he might accidentally go into DKA. That sort of thing doesn't just accidentally happen. You have to do something to make it happen. How did you come up with 83 as the number for normal blood sugar? Any specific studies? Thank you. I originally came up with it, and I mention this in my book, because in the early days of blood sugar meters, it's interesting, the salesmen were good-looking young guys, not pretty girls like they have now. And these guys would come into my office with their meter, and they wanted to demonstrate it, and I'd say, I'm not going to do a blood sugar with your meter. I've had enough blood sugars today. It's your turn. And we'd see their blood sugars, and I'd frequently compare their meter to my meter, and on my meter, their blood sugars amazingly, were all 83, or almost exactly 83. And I figured normal young men, non-diabetic young men, usually have blood sugars of 83. And it took several years, and later on, even many years, for me to see two studies. The earliest study was in the state of Ohio, where they looked at, I believe it was fasting blood sugars, and in the general population, they didn't separate out the diabetics, and they looked at the lowest mortality. Now, how the state happened to have this information, I don't know, whether it was through insurance companies or what, but they looked at several 100,000 people, and they found that the lowest mortality was a fasting blood sugar of 83, which really knocked me over the head. Then years later, there was a study in South Korea of hemoglobin A1C. What was in the general population? Not isolating diabetics, just general population. And again, the lowest mortality in the general population was those with an A1C of 83. So I got it once and I reiterated it twice. I cannot cite the articles offhand, but I probably have them in my files. And I was not about to dig through files to answer this question. I guess I could be bribed with a great sum to go through the files. How important is basal insulin, and can you stop taking it if your numbers are below 125 before bedtime? Again, a good reason to read my book, Diabetes Solution. I try to have normal, non-diabetic blood sugars in my patients around the clock. For adults, we look for a target of 83 and try to keep it there all the time, but it's not always possible. Just before this video, mine was 79. I would like it to be 83. And I'm not perfect, and my patients aren't perfect. I became familiar with well-known Dr. Mcdougall's starch diet, which contradicts your recommendation, but claims that type 2 diabetes can be reversed. Well, I looked at the site that they gave me, drmcdougall.com, and this doctor is selling products on PayPal. And I've warned my readers and listeners over and over that if someone is selling something, don't trust it. Yeah, I'm selling a book, but as any of you who are authors would know, you don't make money writing books unless they're bestsellers. Mine's a bestseller to a limited market, namely diabetics. I plan on doing a 26.2 mile marathon this coming October. Most marathons like to load carbs days before the race, to load up on their sugar stores, or to refill their tanks, as they call it. But this does not sound like a good strategy for me. What do you recommend regarding nutrition in preparation for a marathon for a type 1 diabetic? I think I've answered this in the past, but I'll answer it again. Many years ago, I don't remember how long, there was what was called the stone wall if you were running a marathon. after, I believe it was 20 or 26 miles, the runners would pass out. And for a number of years, no one knew what it was. But then someone smart got around to measuring their blood sugars, and they were hypoglycemic. So their blood sugar may have dropped to 0 or near 0, and they passed out. Now, loading up on glucose for a type 1 diabetic is just going to raise your blood sugar. If you take insulin to cover it, you would think that you're going to store glycogen. But the average human, adult human, cannot store more than 300 grams of glycogen total in his body. 300 grams would have maybe 1,500 calories. Now, it's tough enough to survive a day on 1,500 calories, but to survive a marathon on 1,500 calories ain't going to work. So what are you going to do? And what's going to happen to that, all that glucose that you've been taking for those days? If you take it with insulin, you're going to convert it into fat. So you'll build up your fat stores. And it is possible when you're running to convert some fat to energy, but you cannot rapidly convert fat to energy rapidly enough to cover the marathon. So what I recommend, not only for diabetics, but also for non-diabetics, is that you carry with you these bottles of liquid glucose, or pour the liquid into a larger bottle that you have strapped around your waist, and that you periodically check your blood sugar and consume some liquid glucose. And probably you should be consuming the liquid glucose ahead of a blood sugar drop, and that is in anticipation, so that you can prevent the blood sugar drops. And that requires a lot of practice in advance of the marathon to figure out how often you should take and how much glucose you should take. It's also ideal to have friends stationed along the path of the marathon for you to stop, get a quickie blood sugar, and let them do the calculation of how much blood sugar they should give you based on a table you may have given them. That will delay you less than if you had to figure out how to do your own blood sugar during the marathon. I am diagnosed as type 2, 52 years old and on insulin. I thought type 2s could not have severe hypoglycemia, but recently I became unconscious from a blood sugar of 39. Is that true? Well, if you say it, I guess it's true. And of course, anyone could get unconscious from hypoglycemia. In fact, years ago, it was a method to treat depression by psychiatrists. They would actually give the patients insulin until they became unconscious, and then how they got them around, I don't know, because they would have to give them IV glucose or epinephrine or glucagon to get them back, but they would give them severe hypoglycemia to treat depression. So, and these were non-diabetics that they were giving the insulin to. So you don't have to be diabetic to go unconscious from too much insulin. And don't try taking excess insulin to treat depression. I question whether that trick ever worked. Does an infusion of vitamin C raise blood sugar levels in type 1? If so, is there a solution? Well, more than 4 grams of vitamin C in a dose, whether oral or IV, in one article that I read in a peer-reviewed journal, raised blood sugar. And in many articles, I've read that more than 250 milligrams at a time can poison the enzyme in the blood sugar test strips so that your blood sugars read too low. So, given enough vitamin C, you can have a high blood sugar, but it would read too low. And is there a solution? Yeah, there's a very good solution. Don't take IV vitamin C. There's no purpose to it that I can think of, and there are potential hazards. Does frequent hypoglycemia affect memory? Well, that's a good question. And what's been found is if you have a history of frequent hypoglycemia and frequent highs, a number of studies have shown that diabetics with frequent hypoglycemia also have frequent highs. And the combination of up-down can adversely affect memory. The hypoglycemia alone, if you ignore the highs, is only hazardous if you have convulsions. If you have convulsions, you can have micro hemorrhages in the brain, and I imagine given enough of them, it would affect memory. Now someone sends a long link that I could not possibly recite accurately and says, does this study mean taking vitamin C is good for blood sugar control? And I would say that it is not good for blood sugar control. And it makes it tougher because it destroys the enzyme in the blood sugar test strips, so you can't use the test strips to adjust your blood sugars. Protein has been found in my urine. How dangerous is that to my kidneys? Well, first of all, the protein in the urine is not what damages the kidneys. It's the damaged kidneys that cause leakage of protein into the urine. And in particular, the protein that is released into the urine in diabetic kidney disease is albumin. We now know from a study that I did, actually that I recommended, it was done by LabCorp on thousands of patients, that 36% of women and 36% of men and 40% of women who submit urine for 24-hour urine analysis have high protein and low microalbumin. So there are a lot of people out there that do not have albumin in their urine, therefore probably do not have diabetic kidney disease, but do have excess amounts of protein. And I've proposed a study that I'm hoping LabCorp will do, where we we analyze the protein that is in these urines. What with the COVID epidemic, it's tough to do research studies out there, but one of these days I hopefully will see it performed. And it would be very interesting to know what is all this protein that's appearing in the urines of normal people or of non-diabetic people. I'm a type 2 diabetic, formerly very well controlled on Glucophage XR. Since it has been discontinued and my own personal stash has run out, I've been stuck with various generics from my insurance company. The worst of these, metformin ER by Sun Pharma, had zero effect on my blood sugar, but induced extreme fatigue and intestinal issues. After trying several generics, I am now using Time Labs metformin ER. This doesn't make me feel poisoned like the Sun Plasma product did, but it is nowhere near as effective as the brand name Glucophage XR. And then this person doesn't ask a question, but I can tell you that Merck in Germany makes Glucophage XR. They're still making it. In fact, there's a research study going on at the Albert Einstein College of Medicine and maybe several other medical schools using Glucophage XR that they purchased directly from Merck in Germany. Canada has Glucophage available, and it may also be available in the United Kingdom. And the Canadian Glucophage is available from a number of their mail-order pharmacies, and it's very inexpensive. I think it costs something like $1 a pill, and you might have to take several pills a day. So that's the story on Glucophage. You can get it if you make an effort. We've been successful with some of the generic versions, and we've been very unsuccessful with other generic versions. If you happen to have a version that is working, you should tell your pharmacy that you want that same version with every order. If you do not insist upon that, they will be free to switch versions depending upon whatever is cheapest that month or whatever their distributor is sending over that month. My son is 6 years old. I take him to the lab and A1C was 8.5, which is an average blood sugar of about 240 milligrams per deciliter. Fasting blood sugar of 350. So the pediatrician told me it's definitely type 1 diabetes. No lab in our country makes the autoantibodies test. Now, after 20 days, his need for insulin is declined, and now he's on 3 units of long-acting insulin a day and needs only 6 units for the whole day. What is your opinion? My opinion is that it certainly looks like he's a type 1 diabetic, and he's in the honeymoon period. And if you aggressively normalize his blood sugars, you might be able to perpetuate the honeymoon period. If you allow his blood sugars to remain elevated, the honeymoon period will eventually terminate, and he'll require much higher doses of insulin. And I don't think you have to test for autoantibodies. There's absolutely no need. If a kid has a blood sugar of 350, he's not a type 2 diabetic. Dr. Bernstein, are you in nutritional ketosis all the time? Do you ever test your blood ketones? If so, what is your typical blood ketone level? Dr. William Davis suggests being in ketosis all the time can be detrimental to health. This is why I ask. I can't think of anyone who's been longer in ketosis than yourself. Well, I never test my blood for ketones. I never have a high enough blood sugar for me to worry about ketoacidosis. Many people non-diabetics have fasting ketosis. So you'll see on urine screens, routine urine screens, first urine in the morning of many people, that they'll have a trace of ketones when they come to the lab in the morning. The only time my urine has ever been tested for ketones since I've been measuring my blood sugars, which is, I guess, over 50 years, is when I will periodically, every few years, get a 24-hour urine to see, to calculate my creatinine clearance, see how my kidneys are doing. And the lab usually automatically does a urine dipstick on the 24-hour urine. And they've never had positive ketones on the dipstick. So in the course of 24 hours, every few years, I haven't had any ketones in my urine. And this reminds me that so many diabetics have been advised to show ketones in their urines and to actually test their blood for ketones, which is an utter waste of time. The only reason for testing, that I can think of maybe two reasons for testing for ketones. If you're trying to lose weight and you don't own a scale, and you have a urine dipstick for ketones, and you're not diabetic, so you don't have to worry, or if you're diabetic and you have blood sugar meter, no, it's not high, you can determine that you're burning fat if you find ketones in urine. You can also determine you're burning fat if you find ketones in the blood, but why pay for an expensive machine to do that for you? The real reason for checking for ketones is if you have very high blood sugars. Well, I should put it a different way. If I'm treating a patient who's got vomiting or vomiting and diarrhea and is severely dehydrated, and I want to prevent their blood sugars from going too high, I have to prevent ketoacidosis. And the ADA doesn't care what their blood sugars are, but they do say that if someone's in danger of ketoacidosis, nausea and vomiting, you have to test their urine for ketones. So I have them test their urine for ketones, but what we're doing anyway, which is keeping their blood sugars normal, is preventing ketoacidosis. So there's no value to testing because we're preventing ketoacidosis anyway, but if something happens to them and someone wants to sue all the doctors, if I get caught for not testing the urine for ketones, it's malpractice according to the ADA. The fact that I'm preventing ketoacidosis is not what's important. I am 23-year-old male, weigh about 120 pounds. I'm just curious, as my insulin doses are so low. He's taking about 11 units per day, but he doesn't say what his blood sugars are. He could be taking 11 units per day and have blood sugars of 300. So he's asking why are they so low, and if he's getting away with 11 units a day, and his blood sugars are normal, then he may be either a type 2 or he may be a type 1 in the honeymoon period. But there would have to be near normal blood sugars. I'm a type 1 diabetic. My husband and I are currently trying to conceive our first child, and my OB recommends I switch from Tresiva to Levemir because she does not believe Tresiva is safe in pregnancy. I take Novolog with meals. My allergist does not think this switch is necessary. I have tried both of these long-acting insulins and prefer the blood glucose control I have with Tresiva. For some reason, I gained weight with Levemir and needed a higher dose of it to attain target blood sugar. What are your thoughts on the safety of Tresiva during pregnancy? Well, I do an awful lot of reading, and I've never seen any study indicating that Tresiva is harmful in pregnancy. And because normal blood sugars are so important, both prior to, shortly before pregnancy and during pregnancy, if you're getting better blood sugars with Tresiva, that's what you should be using. And you could ask your OB to cite the studies that show that Tresiva is harmful. Is adult stem cell therapy successful in treating type 1 diabetes? Well, first of all, it depends what you mean by stem cell therapy. There are all kinds of versions of it. There's like injecting stem cells. There's giving substances that transform endogenous stem cells. For example, we know that glucagon cells are stem cells for beta cells, so they can be transformed for beta cells given the right kind of treatment. And I don't know of any studies performed on humans that have cured diabetes or made diabetes milder with stem cell therapy. There may be something down the road that I'll talk about if there's an applicable question. Some medications can restore some beta cell function as a side effect. Why aren't they tested clinically or even used off-label for this purpose? Well, probably because they're generic. For example, verapamil is actually being tested clinically and supposedly has been found to be helpful at preserving beta cell function in early type 1 diabetics and also type 2s at the University of Alabama in Birmingham. And I believe other universities are studying verapamil. There are a number of herbal products that I've used for patients who cannot take insulin. For example, I have one patient who's a pilot, and he actually built his own airplane, and he cannot fly over certain states if he takes insulin. So he's trying to stay off insulin, and we've been very successful using oral agents plus several herbal products like berberine and one or two other products, and they've been successful. But these are generic things that no one can patent. Anyone can prescribe them. You don't even need a prescription. Anyone can use them, and no drug company is going to make a lot of money off of them. Small herbal product companies will include them in their collection of herbal products that are sold for a variety of purposes. And if they make claims that this can improve your beta cell function, then they're violating FDA guidelines, and they can have their product taken off the market, or they can be fined. I am on both long-acting insulin once daily and fast-acting before each meal. My doctor still has me on metformin twice daily and mentioned now that I'm on insulin, I may eventually not need the metformin because I'm insulin dependent. Well, metformin may be of value for reasons other than for the treatment of diabetes. For example, near Barzilai at the Albert Einstein College of Medicine has been doing a long-term study on longevity, where he's looking at people who, at centenarians, people who live to be over 100 years old. And he believes he's found that metformin increases longevity. And he is doing, I guess, the first study of this kind, but other universities are doing similar studies trying to increase longevity with the help of metformin. In fact, Neer is actually taking metformin himself. So there are values to metformin aside from the diabetes. I've used metformin to stabilize erratic diabetes in pubescent teenagers and also in some menstruating women who have blood sugar fluctuations that vary with the menstrual cycle. Now, it doesn't work for everybody. For some people, it makes these fluctuations milder. For some people, it makes them much milder. And for some people, it has no effect. So there are lots of reasons for using metformin. And just because you're a type 1 diabetic doesn't mean that you shouldn't be using it, but there may be no value to it unless it really does increase longevity. What is your opinion on CGMs, constant glucose monitors? The one I'm interested in is the Dexcom 6. Well, I have a Dexcom 6 on my arm, and I find it of tremendous value in catching hypoglycemia at night while I'm sleeping. Now, half the time that it gives me a warning, it's a false alarm, but half the time it picks up a blood sugar that's under 65, so I consider it very valuable. There are problems in that all of the CGMs of necessity are 20 minutes to a half an hour behind the actual blood sugar reading, and they may be sometimes totally wrong, grossly wrong. You might have a CGM reading of 190 when your real blood sugar is 110. This can happen on occasion, and because of that, on the opposite of the claim of the CGM makers that it means no more finger sticks, it's just the opposite. I do many, many more finger sticks since I got my CGM because um, it's often wrong. I have to double check it. So if I get a warning, I have to check it. And frequently the warning is right, and frequently it's wrong. So I'm doing many more blood sugars than I did before I got the CGM. I'm a type 1 66-year-old male diagnosed about 3.5 years ago. 5'11" and weigh 155 pounds, so he's not obese. Thanks to your book, I brought my A1C down to 5.6, which is an average blood sugar of 124, from 14.9. Wow. My doctor, who is a Kaiser doctor, wants me to start taking rosuvastatin to reduce risk of heart attack and strokes and blocked arteries. My lipid panel came back good except for a slightly elevated LDL. Now, you may recall from my prior comments that an elevated LDL is not indicative of anything. An elevated oxidized LDL is a warning. An elevated small dense LDL is a warning and could be a potent warning. Elevated lipoprotein small a is a very potent warning. Elevated ApoB is a warning. So just looking at the LDL is dark ages. I really don't want to start taking a statin because of potential side effects unless absolutely necessary. Is this a case of their guidelines being a one-size-fits-all, or am I really at risk and need to start taking rosuvastatin? Well, first of all, it's wise to look at your blood sugars and your A1C. Your A1C is slightly elevated, so, but it was previously 14.9, and if it was that high for a number of years, you could be at great risk because high blood sugars do damage the arteries. You probably would be wise to get coronary artery calcium score to see what the current status of your coronary arteries is. And the blood tests should be the true risk factors, not ancient risk factors that have been invalidated. And in my prior videos, I've mentioned a number of the true risk factors. I'm not going to go over all of them now. I've heard of type 3 diabetes and the links to Alzheimer's. If so, your comments. Well, the term type 1 diabetes has been applied to Alzheimer's disease because there's some evidence that there's insulin resistance in the brain in patients who have Alzheimer's disease. You could take a look at the Mayo Clinic, this site, mayoclinic.com, .org, mayoclinic.org, to see what they've found about what they call type 3 diabetes. Thanks for listening or watching. Our next video and teleseminar will be September 30th, 2020. Thanks again.